At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Thank you, Lauren, and welcome everyone to Accelerating Nursing Electronic Health Record Usage, part of the Clinical Adoption webinar series from Canada Health Infoway. My name is Cindy Hollister. I'm a Director of Professional Practice with Infoway's Clinical Adoption team and will serve as the moderator for today's webinar. I'm going to get a few housekeeping items out of the way, starting with this notice about the webinar being recorded and that it may be posted on our website. And as you've just heard, all participant lines are muted throughout, so you will need to use the Q&A feature if you wish to ask a question. And this just shows you how to use the Q&A feature by clicking on the drop-down arrow at the top to select Q&A and sending your questions to all panelists. We do encourage you to submit questions throughout the webinar, and they'll be addressed all together at the end. The next slide is just our disclaimer, and I'll just give you a few moments to read this on your own. Okay. We'll be following this outline for today's webinar, providing introductory background information about Canada Health Infoway, a brief overview of the Pan-Canadian Nursing EHR business and clinical requirements supporting clinical practice, the reference document, and reviewing some recent national nursing survey results to help set the stage for our guest panelists. The featured panel presentations will be delivered from a primary care, acute care, and provincial territorial perspective. And after the panelist presentations and a brief summary, we should have a good opportunity for questions and answers. So in front of you are the objectives for today's webinar: to look at available resources, showcase local use of the requirements found in the reference document, to discuss challenges and opportunities associated with accelerating nursing EHR usage, and to identify how Canadian nurses can participate in accelerating usage of the EHR and how nurses can be involved and contribute further. So joining me today are guest panelists: Ethne Reichert, clinical consultant with RWI Informatics Incorporated; Pamela Thorstensen, Director of Professional Practice, Nursing Fraser Health Authority, Surrey, British Columbia; and Patricia Rothney, Business Analyst, Project Manager, and Subject Matter Expert with Global Village Consulting Incorporated and the Canadian Nursing Informatics Association President. As each panelist presents, they'll start with a bit more background about themselves, but now I'd like to take a moment to find out a little bit more about today's webinar participants by use of a few polling questions. So this first part of this question, of the polling question, is actually one that you can actually include multiple responses. So that might help if you're sitting in a room with a number of people, or it might be that, in fact, your role includes multiple areas. The second question is just the yes or no, so just one response for that one, please. So if you are in a room with many people, I guess it'll be majority rules. Oh, I see from one of our participants that they can only choose one response for what is your role. So I apologize for that. But if we could get the responses, that would be great. This gives us a little bit of an idea of who's on the call. There we go. all of us a moment to take a look at that. So it looks like we have a fairly experienced group in terms of participating already in digital health projects. Okay, we'll move on with the introduction. So Canada Health Infoway was created in 2001 to accelerate the use and optimization of digital health across Canada. It's an independent, not-for-profit corporation, and it's accountable to 14 federal, provincial, territorial governments. And you can see here our vision of healthier Canadians through innovative digital health solutions. And Infoway is really, as a priority, looking to leverage existing investments and take advantage of trends and emerging technologies to improve the patient experience. EHRs, electronic health records, or EHRs, support the notion of one patient, one record, or a lifetime record containing essential clinically relevant information about a person, such as demographic information, encounters, results, and images, problem lists, medications, and immunizations. Infoway's blueprint infrastructure allows information contributed from many different points of care being available in an EHR for viewing where and when needed to support client, resident, or patient care. Having this clinically relevant information securely available to authorized providers across care sectors helps support interprofessional communications and collaborative care focused on the patient. Infoway's clinical engagement strategy brings together clinicians in leadership, practice, and education to ensure clinical value is achieved in digital health. As a result, Infoway supports clinicians in the ongoing adoption and use of digital health in Canada through investments in modern point-of-care solutions, clinical peer leader networks to share best practices, clinicians in training initiatives to help prepare new graduates to practice effectively in technology-enabled environments, change management tools and resources, and engaging clinicians to advise on projects and strategy. This next slide, I'm just going to step through what the development process was for the nursing EHR reference document. So we've just heard that Infoway's clinical engagement strategy of linking with clinical leaders is, we've heard about that, and it's partly done through 4 clinical committees, one of which is the Nursing Reference Group, comprised of nursing leaders from across the country. And it was actually this Nursing Reference Group that early on recognized the strategic importance of proactively identifying key EHR business and functional requirements for nurses. In September 2010, the Nursing Reference Group established a nursing EHR data working group to identify these requirements. A consensus approach for the iterative development was used with guiding feedback along the way from the Nursing Reference Group and input sought from all members' colleagues. A year later, in September 2011, the working group delivered a draft of guiding principles, assumptions, and over 150 nursing EHR business and functional requirements, along with an EHR clinical scenario that was created and used by the working group to support the development effort. The Nursing Reference Group embraced the work and recommended that a small focus group of nurses currently using advanced technologies in clinical practice be engaged to review and validate the requirements. That was done, and the resulting work was first made available on Infoway's website in June 2012 as a reference document. Encouragement to test, leverage, and help continuously evolve this body of work can be found in the document's overview section. So this is what the Pan-Canadian Nursing EHR Business and Functional Elements Supporting Clinical Practice reference document actually looks like, as found on the Infoway website. And inside of this is a list of all the Nursing Reference Group, EHR working group, and focus group members that were formally involved throughout the development. In total, 42 nurses from across the country. Inside the cover now of the reference document, you'll see this framework used to present the 35 business and 122 clinical EHR requirements. A few examples of these requirements include things like search and filter capabilities, adjustable font size, displays information sources and details. So from these examples, you might realize that while the development was clearly EHR focused, the majority of the requirements would readily apply to point-of-service applications and systems, or could be easily translatable. Building upon the clinical scenario, first used by the Nursing EHR Working Group, another resource was developed to help illustrate the development and use of the Pan-Canadian Nursing EHR business and functional elements. This tool, also available on the Infoway website, illustrates patient-centered, interprofessional, collaborative care and provides some examples of the actual requirements as Mabel, the patient, transitions between care sectors and providers. So with this, Lauren, we'll turn to our next polling question. And that's, prior to this webinar, had you heard about or used this Pan-Canadian Nursing EHR business and functional elements to support clinical practice reference documents? So this is a one response, so again, majority rules if you're in a group. So it looks like the poll's ended, and we should be getting the results momentarily. Ah, great. That's good to know that as a baseline. Wonderful. Thank you for that. So most people have not heard of this reference document before. Now I'm going to finish off the introduction with bringing you back to the promotion of this webinar, in which we cited some results from a national nurses survey that we hope did catch your attention. Canada Health Infoway partnered with the Canadian Nurses Association to conduct this national survey of Canadian nurses' use of digital health technologies in practice. It is the first ever quantitative survey of Canadian nurses to explore their access to and usage of digital health in nursing practice. So it was the survey results that you're about to see are based on 1,094 nurses involved directly in clinical practice. So what do nurses say? The good news is that the vast majority of Canadian nurses recognize digital health as a key enabler to help deliver better patient care and improved efficiency. I'll let you read through the results there. But really positive and, you know, quite showing that they're ready and lots of capacity there. But while nurses recognize that digital health tools present a range of benefits for both themselves and their patients, there are a number of factors impacting the full realization of nursing practice enabled by digital health solutions. So let's take a look at these on the next slide. 57% of nurses say that the legacy systems and tools at their disposal are not adequate for their role. 61% report the use of both paper and electronic systems to access patient information, so living and practicing in a hybrid world. 54% report having multiple logins to access different clinical systems and inadequate tools and access for their roles. 65% of nurses currently using digital health tools use them mainly to enter and retrieve patient notes. And of particular note, are the results that few nurses in clinical practice providing direct patient care agree that they were consulted about decisions to introduce or influence the use of electronic clinical information systems and tools in their workplace. So while this result underscores that more needs to be done to address frontline nursing engagement in the workplace, it also represents a call for action to ensure that frontline nurses are well informed to participate and articulate their needs. So now I'm going to turn this over to Esme Reichert, our first panelist, to tell us how, from her experience, these EHR nursing requirements have been used in the primary care sector, along with some of the opportunities and challenges that have been identified. Esme? Esme, you may be on mute.
Okay, sorry, Esme Reichert, sorry. I've been working in nursing informatics for over 10 to 12 years, and most recently have been working with implementations of clinical systems in team-based care, in primary care specifically for the past 3 to 4 years. In this section, and if you go to the next slide, I can talk a little bit about where we use the clinical business and functional requirements in developing ways that we could use an electronic medical record to work for nurses, for nurse practitioners, but we've also had been using it for implementations with the pharmacists or the dietitians. And we also, the expanded role for nurses where they're not in the acute care or primary care major role, but they're in an augmented role for programs such as sexual health, mental health programs. Or we also have been seeing the clinical nurse educator where she's providing chronic disease management or even case managing or elder care. And so this has been a way of taking the nursing requirements and being able to look at an application that is potentially medically modeled and been able to use it within that team-based environment. In specifically, we use the key clinical business requirements that are on the slide. One of the ideas was the right to access the record, and this has been a significant challenge and opportunity for nurses to be able to see what the doctor has put in as well as connecting to a nurse practitioner. So what we did was we looked at professional responsibilities to be able to authenticate that they had the right to access that record and also to drive the permissions for what information they need to access, when, and how. We also found this source of information was needed to be known and understood. And in that requirement in the document, it was understanding from a provincial perspective. However, even in the team-based care, they wanted to know that that was the pharmacist who entered that information, not the physician or the nurse practitioner. And if a nurse was entering it, she was doing it for a specific purpose. So we had to work around that requirement and understand how each provider role was may be affected in the fact that we have a shared record or a record that other providers might be using. The requirement of usability was significant because it was sometimes hard to implement clinical processes for nurses and allied providers that aren't in your typical medical model of a physician office. Many of our nurses work or our providers work in different programs or chronic disease management roles. We also had some areas where they were using it in the home and then having to come back and document. We also had issues with medication reconciliation, for example, where an electronic medical record is really set up around ordering and prescribing and not necessarily validating and updating. And in some cases, we had nurses that were able to adjust medications as a sort of a transfer of function, and so we had to figure out how that usability would follow through that clinical process. The collaborative practice was significant as well because as nurses tend to work in a group environment, they want to be able to share that information with other folks being other providers as well. And of course, the patient and family-centeredness, as I spoke to, the fact that we're providing care in schools, maybe long-term homes, maybe in community programs, we use the requirements to help understand that aspect. So in some of the care coordination requirements, it seemed to be more about the case management, wayfinding, and being able to schedule across teams and understand who would be where at what time. And that was very helpful in the primary healthcare model. And the reporting aspect, as usual, everybody wants to get the information out from the system, but when you're starting to report against a shared record, everybody has to use the record in a certain way so that we can always get the report that reflects their requirements. And in some cases, the reporting works much better for a physician-modeled environment than it does for the nurses or for the other allied health. If you can go to the next slide. So we looked at some of the opportunities here, and I just want to speak a bit about this. We did develop a shared record approach, a single patient record through our primary healthcare model. We worked with the privacy officer, and we understood this from the processes that currently were in place with people providing information back and forth amongst the team in paper. And that helped really helped us understand the access and privacy requirements around that opportunity. We did have to augment the EMR significantly, and we were lucky with our vendor who provided a lot of support to allow the roles and permissions to be configured to appropriately meet both access and privacy requirements. And we also worked on the governance section with the shared record, so we knew that who was the ultimate authority or responsibility for certain aspects related to the electronic shared record, so that we could follow and understand about release of information and permissions for access. In terms of other opportunities, we found that the team-based care model was significant opportunity for the coordination of care and management of chronic care within the community. Transferring information from site to site is usually done by phone calls or by paper trails and faxes and uploads and whatever. In the team-based model of care with a shared record concept, we had significant immediate opportunities to take a look at what people were doing with the care service, be able to send a little communication and say, take a look at this, I need you to follow up on that. And so we found where we could share the record, there was still a great opportunity, but we still protected the patient's privacy. You did not get access to the record unless you were part of the care team. And when you were finished with that care process, then you were restricted again. So for some of our teen care where they were working with programs, they would come in and provide a service for a period of time and then come off of there again. And that also led to the opportunity for standardization. So we had to agree how and where we were going to store information in the electronic record so you knew where to retrieve it. We had to agree where and what you were going to document, and we certainly had to agree to abbreviations, codes, and processes to make sure that everybody understood what was in the record. So our challenges, our big challenge, I think, if you go to the next slide, was the medication reconciliation, as I mentioned, for nurses. So trying to understand that nurses can do some medication validation and maybe some altering of doses, and how do we make that work within our technology? And of course, we did have a lot of varied processes for nurses. So an RN is not an RN in primary health care as well. So we had to understand their clinical process and then augment the EMR to support that. Still a challenge is computer access for nurses. Both local and provincial IT policies are in place for that. Nurses don't tend to have their own laptop that they can use. They often have to share a laptop or share services. So that's a significant money amount for nurses in primary health care. And again, the shared record management and accountability means you have to sit down and talk about it and figure out how you're going to manage it. Also, our time was required for one-to-one support and optimal use of the maturity level. So if a nurse started to use it quite well, but then we needed to go back and sort of help her really get to that mature level and how she could rethink how she's doing her processes from paper to electronic. We did find that we had to go back, and that was a bit of a challenge in terms of our time. The other last point I'd make was there was a little bit of challenge between what was a local clinical decision support and what was a regional clinical decision support, and then again the provincial. So if we were putting in a drug, is that a local decision, or is that now a shared record decision, or is there something related to the provincial pharmacy information system that we need to do it in a certain way? And that also led to some of the integration with our jurisdictional systems, where it worked really well in the EMR, but when we did our lab interfaces, it only goes to doctors, it doesn't go to nurses. As we're starting to talk about, pharmacy, we're starting to think about, well, how are we going to work that together with our nurses? So the business requirements and clinical functional requirements was very helpful in being able to augment the technical solution to fit our clinical processes. And I'll hand it back to Cindy.
Thanks, Stephanie. Now I will hand over to Pamela Thorsteinson to speak from the acute care perspective.
Thanks, Cindy. Hi, everybody. My background is nursing focused, so I'm not in informatics coming from that lens. I'm coming from a nursing practice lens. And we've been involved in supporting the work to try and move the electronic record forward in acute care with the documentation system for nursing and also with the allied professions. So we could just go to the next slide. So currently in acute care, we have a platform that is well in use in terms of patient admission, transfer, discharge, order entry, visualizing lab results, PACS is online. Pharmacy applications are in use for them to be able to enter the drug systems, but these are not yet into our the pieces that the nurses would be able to access other than an MAR. We do have areas where nurses are documenting online and in some of our clinic areas, but the majority of nurses in our acute care system currently would be documenting on paper-based systems. And our allied professions, we have some online and some in paper-based systems. And currently there's different platforms in the community sectors, so primary care, mental health, public health. Other health authorities, there's a bit of a mix. We have some that are on the same system as us and some on different systems. And lots of work in progress basically to prepare to move to an online documentation for nursing and the other professions. So the goal of this is very much to make it a client-centered system and very much support the interprofessional, just as Ethne talked about, the team-based approach in acute care, and then looking at how that can go across. You may hear some background noise. We have a happy bunch next door, so if you're hearing some laughter. The other work that we're doing is really trying to look at consistent languaging. So as the patient or client resident moves across our system, are we using the same languaging to communicate? And so looking at some of the systems internally around that. Likewise with clinical decision support, we have standardized policies, clinical decision support tools throughout the organization, and so it's looking at how do we bring those into the system as we're developing it. Concurrently, there's preparations underway for the computerized physician order entry and looking at pre-printed orders and order sets, and then again, how do we correlate these decision support tools within. And then also looking at considerations for closed-loop medication, bedside medication verification, and med reconciliation. And we did look at the implementation of MedRec electronically and are needing a little bit more robust systems to be able to document in that format. So we're continuing for now in a paper-based system. If we can go over to the next slide. So the opportunities that this presented for us was really to be able to create awareness. So the functional element document was circulated at the time that we completed this work to, I'm a member of the nursing reference group and the subgroups. We completed it and we sent it out to all of our partners. So we have a regional nursing professional practice council that was sent to. It was sent to our exec, our health informatics partners, and it was used as a resource in terms of helping us guide what some of the considerations were as we move forward on this. A lot of this was already in place, which was great. So in terms of the privacy requirements, that type of thing was already well supported, well recognized, and we're very fortunate that our health informatics folks, a lot of coming from a nursing background, so they get it, they know, what's needed, why it's needed, so very strong support. In terms of standardization, it also gave us the opportunity to create some consistent requirements. We still had a lot of folks doing narrative charting, and we wanted to really obviously move towards more focal approach as we're looking at what that would look like electronically and within professions and across professions. We were also able to establish common abbreviations, acronyms, and symbols. So those are in the process now of starting to look at how those are going to be implemented. And likewise, care standards. So being able to establish these. Our system is 12 hospitals. And so within that, within clinical programs such as critical care, emergency, renal, et cetera, and then across populations, older adult, pediatric, et cetera. So looking at what those care standards should be and using that as a base for what would eventually look like. Likewise, some current work around form standardization so that we can get people consistently using those and then be able to sort of make an easier switch once we go electronic. The little diagram there was just a snapshot that we were able to, our health informatics folks were able to prepare for us to bring to the point of care staff to be able to demonstrate to them what this could look like. That was one of the biggest challenges, was people's awareness of what this actually looked like. As Ethne identified and Cindy was speaking to in the survey, a lot of the considerations for nurses are the challenges that they find in terms of computer access, difficulty logging in, concern about increased workload, et cetera. So it was really helpful to have these tangible examples of what this could look like and get their input. And this is just an example of one that we used. And then lastly, in terms of opportunities, just wonderful opportunities for partnership. We were able to establish working groups that went across professions, programs, and services and hear updates on what was happening in other sectors and apply those considerations to the acute care build as we were going forward. And go on to the next slide. So challenges, just like the awareness was a bit of an opportunity, it's also an ongoing challenge. And that desire for online documentation. I've had a few nurses say to me, I'm going to retire before this comes in. And so there's that concern factor in terms of what that's going to look like for workload, for functionality, for access to their patients. The current computer access is still a challenge. We have areas where it's more difficult for nurses to get access to a computer on a unit. Their own familiarity with using the computer can be challenging. And then the implications for the different professions, for those allied folks that are already on an electronic system, looking at whether they would be switching to a different system or platform, within the functionality that we were looking at. There's also challenges ongoing local jurisdictional considerations and just in terms of what are provincial requirements, what are health authority requirements, and then always with any project, timelines, funding, resources, and the people to do the work. So that is an ongoing consideration that will continue to be addressed. we are seeing some challenges with the clinical standardization, so although there's been great work, it's still an ongoing prioritization need to ensure that that is front and center with our clinical programs and services and professions, that there is this intent and full support to standardize things within and across. Getting input into the system design is absolutely crucial, and so really wanting to keep those connections with our frontline folks so that we are able to take, like the sample that I showed you, something tangible to them, get their input on what works for them, doesn't work for them, and then move forward as we go. And system interoperability, there's some concurrent work happening in terms of getting the different platforms to talk to each other, but this, as you can appreciate, is the ongoing challenge is information is sent back and forth, is it in the language and the format that you need. And then looking at what was already existing, wherever there was an available roadmap of who'd already done this, how they'd done it, what templates they've used, all of that was very helpful where it could be accessed, and that would be a great opportunity going forward the more that we can share that information across. So I'll wrap it up there and turn it back over to Cindy.
Thank you, Pamela. And now I'll pass this over to Patricia to speak from the provincial territorial perspective.
Good morning, afternoon, everybody, depending on where you are. Yes, I've been nursing for quite a length of time, and my primary area of nursing practice was maternal child, mostly pediatrics, and I turned my practice focus to informatics in 1996, so that's 18 years ago, and have seen a tremendous shift and growth in this area of practice, and it's a very exciting time. So what I'd like to do is just start with my first slide, please, just giving you an overview nationally of where we're at. So Infoway, as Cindy had explained, has been around for a significant amount of time with the objective of getting a national record in place. And what is happening is provinces are in varying stages of development and implementing and providing access. So those are three distinct steps that are occurring in order to get each jurisdiction and territory equipped with an EHR. And that has allowed a lot of national sharing and learning across the country, as some are out in front and some are just beginning, or an area that one province has focused on and has expertise will share with the next area addressing that. So it's created an opportunity and an environment for great collaboration. I have a sense, and it's my personal sense, we are reaching a bit of a pivot point. People are finding themselves now with stabilized basic environments for their provincial EHRs and territorial, and they're now looking at moving beyond the base functionality and being able to do development more rapidly because all the foundation's in place. And they're turning their attention to adding key clinical content. For the most part, the EHRs are static report repositories. Very limited interactive patient record functionality exists. With the province I'm working with now as a consultant, they do have chronic disease management documents that are interactive based on your access to the EHR, so that all those providers who are addressing, say, a diabetic's care can interact around that patient's ongoing and incremental record and map their progress and next steps. Historically, access strategies have not been in nurses' favor. They've been mainly focused on physician access as a role-based focus, and the practice area that was in most need of addressing was emergency, so it also has been a priority in a few of the provinces. As Ethne was speaking, we are now seeing greater effort around electronic medical records, which is the primary care arm, and the acute care from Pamela. They all contribute data and patient history and activity into the electronic health record for the jurisdiction. And my sense is that there's minimal awareness of the nursing EHR requirements, which the poll actually has validated today. Next slide, please. So what are our opportunities? I think awareness is very much in front of us, and where we can start to move to a more comprehensive understanding of nursing's role in the care of the patient. And building on the team-based care for primary health care, interprofessional approaches are a thrust of Health Canada, and many jurisdictions have picked that up and are moving forward with it. So from that perspective, we need to build the awareness within our organizations, associations, networks, and colleges, and I mean the registrar colleges, but also in our academic programs, that in fact there is a picture of nursing that can happen through the vision of the EHR, because we're not there yet, that we need to be aware of. We need to be spokespersons and champions for. But this will take some intentional work and some intentional communication planning to do this well. But the second point is to raise awareness specifically with nursing leadership and to be bold in equipping them with what they need to be bold in terms of participation in project planning and scoping. Where would they decide what will be included and what not? We need to build within our leadership the awareness of the possibilities and potential of these applications and processes to enhance patient care delivered by nurses. There's a great opportunity that as we provide more and more frontline nurses with access to systems, that we add to that their understanding of what the larger record can do jurisdictionally, and that the nursing requirements really start to paint the picture for them of the opportunity and potential of what they could do excuse me, within their practice and contribute to the interprofessional team, keeping focused on the patient and having the patient drive the processes so that you're not looking strictly at one piece of activity around the patient. You're looking at all of the care providers and how, in fact, they need to interact, and to open that up so the patient can be situated in their preferred location, which is at home as much as possible, not constricting communication and collaboration. So as an action, I see that we all can tell the story of Mabel Lambert and her hip replacement, which is what Cindy showed you. It's the clinical storyboard that supports the functional requirements and is depicted in the graphic of the wheel that shows all of the interprofessional engagement with that patient and how the system can support communication and care. But also to put your ear to the ground in your organizations and your jurisdictions. Where is their efforts around the electronic health record or a clinical record system at the point of care, which is always the first step? And invite yourself or encourage nursing to be at the table and do what can be done to encourage nursing direct engagement at the point of design. And one point that's not on the slide is we need to link interprofessional practice to all of these informatics initiatives, because we can then promote nursing working to full scope of practice. And it's beginning to emerge through the primary health care, team-based care. And in acute care dialogues through the design phase, my experience has been it's a really key point in time to bring that interprofessional approach forward. And when you have all the disciplines around the table, and to begin to understand how each piece of the care team or each member and each piece of care delivered in the team model moves the patient forward much more rapidly if it's done in a coordinated and sharing fashion. Next slide. So just taking a couple of pieces from the presentation today, one is around the survey results. And I think we're in a challenging period of time, and it's reflected in the 2 pages of results that Cindy shared. And that is, as all projects are defined by a scope, there's only so much you can do. There's only so much that people can absorb as change. And by working in these phases, as we call them, no one actually gets a really big picture or a grasp of where the vision will take us. So you end up in a transition gap that you see multiple documentation points, whether it be electronic and paper. You still haven't eliminated, and never will, communication points, but they're not as efficient as they can be when you have the full system in front of you. So I call it the transition gap. We have the vision, we've started on the journey, but we're in the middle. And in the middle is quite painful and feels restricted. And you're not really seeing the full benefits yet. And that's compounded by the physical access challenges that the others have described. It's about enough technology, the right technology. Does it need to be more portable? Making sure that there's no restriction on those who get access within their role and within privacy requirements, of course, but not to put artificial barriers around that. So from a leadership perspective, informatics is a specialty of nursing, and there is a gap in the number of nursing informaticians in leadership roles and executive tables across the country. And over the last 5 years, that really did emerge as an issue because they were decreasing in number because there's very few. When you have an informatics leader at the table and a nursing informatics leader, you're championing the nursing components of the initiatives. You're ensuring nursing is reflected correctly, impacted positively, and you can potentially endorse a project that would close a loop in nursing practice, so a start-to-finish process. And MedRec is, medication reconciliation is one of those processes where nursing is heavily involved, but they don't own completely. But the more people who understand that every piece from assessment documentation and outcomes can be closed and create great satisfaction for that practitioner. There's also a gap in comprehension of the importance of the nursing's role in this systems initiative because by sheer volume, there's many, many nurses involved and are many, many nurses impacted. And we need to be aware at the outset of a project that this is a key stakeholder group, although the physicians can be drivers, but there's also other providers such as nurse practitioners and changing scope of practice and new practitioners coming in that we need to be addressing. So midwives, NPs, nurse practitioners, clinical assistants, you have to look at them all and ensure the system does not become a barrier to practice. And there's tremendous competing demands for nurses' time. We all know that there are not enough nurses in the system and that we are only learning now to creatively use everyone well and to acknowledge full scope of practice to help the system meet the patient needs with fewer people. But it also takes leadership support to release the practitioners and put it as a priority. And the financial challenge of that is backfill, so that you need to know that the frontline care is still being delivered with sufficient persons of the right knowledge and skill set, but also you've given the right focus and the right resources to the project. Nursing also brings the perspective of the best practice and what efficiencies would be helpful. And so the person who is offered to a project needs to be the right knowledge source, plus a practitioner with on-the-ground expertise. And that mix is sometimes hard to find because those who do the work don't always have the capacity to articulate it and translate it into an initiative. We also have gap in funding support for specialized nursing informatics works, the sustaining of the clinical informatics role post-project. It's when you get into the implementation and living and breathing of the system that's left behind the project that the roles can be most impactful. Because when you're doing maintenance support and resolution of issues, nurse clinicians focused on informatics can look at the system and its functioning, assess and diagnose issues, and when they look at the resolution of the issues, they understand the processes such that they can anticipate the ripple effect. There's always downstream to a change. You need to anticipate and prevent inadvertent errors and issues by understanding and preempting and designing appropriately. So from the project perspective, just to close, as I said, the practice is physician-focused first for provisioning and access. And we need to be very supportive and very open and putting it on the table that we need an interprofessional approach and to acknowledge absolutely the physician needs the access in the first wave, but there's others who actually can prescribe within scope of practice. And it may or may not be your class persons. So I know in a province I worked previously, dietitians do ordering within scope of practice. RTs do ordering within scope of practice. Then there's the NPs, the physicians, clinical assistants, all the classic roles. We need to begin to move our design of a system away from a single practice area to around the patient. It needs to be driven around their episode and flow through the system so that we can more comprehensively address their needs and preempt issues. But the counter challenge to that is budget and resource constraints. And budget always feeds into time, because if you have a high volume usage of your dollars to get work done, then you're impacting your timeline as well, because the money will run out. And finally, just to speak a bit about layers of applications for sharing of information, one of the greatest challenges when embarking on an initiative is understanding where your data is coming from, and that we're living the legacy of how systems came into place. And often it was on a distributed leadership model, so that a region within a province was given direction to take care of their own lab system, so they would go out and purchase and implement. Or all healthcare process decisions belonged at a site level, or policy belonged at site and regional levels. And now what we're trying to do is to bring all the patient information wrapped around the patient, regardless of where they present for care, and that's across the whole spectrum of care delivery, and to get a comprehensive picture. So it takes significant effort to understand how these systems can begin to share the data, and we can build those repositories to be as complete as possible and to drive patient-centered care. Thank you.
Thank you, Patricia. So in summary, the Pan-Canadian Nursing EHR Business and Functional Elements Supporting Clinical Practice is a readily available reference document intended to be informative, not definitive, and that provides useful guidance for clinicians, vendors, and implementers, ideally during the planning, design, and implementation of EHRs. You could even use the document to evaluate current systems in place. Please keep in mind that the EHR business and functional elements found in the reference document are the result of a consensus process based upon the best current evidence and thinking at the time. So not all elements will apply in all circumstances, and there may need to be adaptations to particular situations. However, we do encourage you to test out and use the requirements reference document content to help inform and validate your work, and to continuously improve the requirements over time as healthcare and digital health technologies continue to evolve. Please let Infoway know of any comments or suggestions for improvement that you may have by contacting us at the clinical adoption email address that you'll see there. And I'm just going to ask Lauren to put up our last polling question, and this one I am told will allow you to put in multiple responses. And while you're doing that, I'm just going to actually have the next slide up, which shows you some additional resources that are available. The Knowing is Better for Clinicians, Pan-Canadian Clinician Peer Network Community, and there was an earlier presentation in July that provides more detail about the development of the requirements that you'll find in the reference document, and that was a presentation done for the Canadian Nursing Informatics Association and is available on their website, the presentation. I see that we've got one question regarding the backfill of interprofessional staff. So it's speaking to, can you expand on what backfill will look like?
I can speak from the perspective that I lived in a project, and what it was is in Manitoba, the electronic patient record, which is the acute care-based record in that province, was designing a provincial application but implementing at one focused tertiary site. And the agreement made is that any hours that the frontline clinical folks were engaged in the project would be banked, and there was a percentage on a special request only that was funded for backfill. Most of it was a tracking. But it's about understanding if there's key roles required that truly you can't go without at the front line, there needs to be consideration in your project in order to access that resource and include that in your funding.
Thank you, Patricia. So I'd maybe direct this question to all panelists. What do you think is the highest priority to move the agenda forward in accelerating the use of EHRs by nurses and other clinicians?
So this is Ethne Reichert. From my perspective, part of it is that we have to understand that nurses need the technology tools. Right now, I think that's the biggest barrier for nurses using any sort of technology is they don't have computers on at their workplace, or they're not allowed to use their digital units, their phones or their iPads, to help facilitate both patient education and also documentation. So that, unfortunately, is stopping a lot of use. Once they have something that they can use, they are more than willing to use it.
Thanks, Ethne.
Hello, it's Pat. In addition to what Ethne says, because I totally agree, you need to have something that the nurse sees as value in their practice available to them on the electronic record. If all you have there is related to demographics, which is important, I'm not downplaying that, or orders, but the orders don't contribute to a list that the nurse can chart against, which would replace the pocket piece of paper, something that brings immediate value to the nurse. There's less drive to enter the system. Nurses are information consumers, and they are tremendous knowledge resources and producers, but there is not necessarily a nursing focus on the exploration of what first needs to be developed in the system, and from ensuring that it brings immediate value to nursing.
Well, here I would just add to what Pat had identified is that secondary use as well. And so in terms of designing the systems, as you're looking into those considerations thank you for the comment about point of care. I totally agree. So the point of care nurse, whether you're in acute care, primary care, residential care, whatever your practice, that ability to pull the data afterward and bring it back to the clinician at that point of care. So that piece, extending from across the spectrum, from point of care to whatever level of decision making, nationally, provincially, et cetera, to be able to show the value of that data. And that's one of our biggest challenges, is that we have a lot of issues. I was in a meeting this morning with nurse practitioners and encounter codes and data going into a system, but we're not able to retrieve that data back and be able to have it inform practice at the point of care, but also through to system planning.
Thank you, Pamela. I see that we've had more questions come in, and we will have those questions and be able to address them for you. But we're at the top of the hour almost now, and I'd like to wrap up by thanking Ethne, Pamela, and Patricia for being our wonderful guest panelists for this webinar. A big thanks to all of the participants, and thank you for providing your responses to the polling questions. And I'd like to let you know that there'll be an evaluation that will follow within a week of this webinar, and that should also include links to the webinar materials. And I'll now take this opportunity to thank Caitlin Burgess for her support from Infoway Communications to make this all happen, and I'll turn it back to Lauren.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.